We shall now have Dr. RITU Arora showing her case, and she's a medical director, a cataract from Vision Plus Eye Hospital Eye Center based at Delhi. And she's a very efficient cataract and refractive surgeon. And let's see what she has to show. A challenging case, no doubt.
Thank you, ma'am, for this very kind invitation. And I'm so honored to be here. I'm just sharing my screen. Can you see my screen, ma'am?
Yes, yes.
So this is a case of a 65-year-old one-eyed patient who had an adherent glaucoma and a very dense cataract. She also had a very shallow AC, a small pupil, and that was, quite challenging. So it was a deep set eye, so I had to sit temporally. Otherwise, I would have preferred to sit superiorly with the adherent glaucoma being on the nasal side. And after doing the sinucal lysis staining and doing the temporal corneal incision, I decided to put the iris hooks because the pupil was not dilating at all. And once I've got a good visibility, I do my rexus using a cystotome. And it's important to get a good sized rexus because the cataract is quite dense. And as I start doing the rexus, I also realized that there is some amount of zonulopathy. And I realized that this is going to be a little difficult and more challenging than I expected. So I do manage to slowly get a good rexus, and it's not very large, but I think it's adequate for this kind of pupil. I do a gentle hydro dissection and making sure that I do it in different quadrants to loosen up the cataract. It's quite dense. It's a grade 4 cataract, and I do get a good rotation. So I start off doing, I decided to do a stop and chop in this case. And I'm making a wide trench, but the visibility in the nasal part is not too good. And that is where most of my chopping is going to be. So after I've made a sort of deepish trench, I try to crack it, but I'm not really very successful. I don't get a very good crack. It doesn't go through and through very well. So I rotate it and I continue doing the chopping. At the same time, I know the AC is shallow, so that is another part. And there's a lot of pooling because it's quite a deep set eye and there's a lot of pooling, so visibility becomes a bit challenging. So I'm trying to do the cracking. I'm not getting a very good view, and then I deepen the trench so that I get the posterior plate get separated well. And I managed to finally crack the posterior plate. So in these cases, you have to be actually very patient. Don't be in any kind of hurry. Take your time, because even a small error can lead to a problem. So I'm going slowly, trying to get smaller pieces, and slowly and steadily I manage. I remove one piece because it's a dense cataract, as we just discussed, to make the maneuverability better. And finally, I manage, taking my time, I managed to get the pieces one by one. But there is some adherence, and one needs to refill the chamber with viscoelastic from time to time. Since it's a shallow AC, one wants to be careful. It's a one-eyed patient, so you want to be cautious that you don't damage the endothelium. So I take my time, I fill in the viscoelastic again, and finally, yes, I have it almost done. So I get the last piece out, and it's a sigh of relief for me. So I do a careful eye, knowing that the zonules are weak, and at the same time, I can see a few folds in the posterior capsule also. So I know that there is some amount of posterior zonulopathy. But at the same time, I decide to put in a single piece lens. I could have put in a CTR also at this point, I feel, but I was just keen to get through and over with the case. So the lens is well placed, well centered, and that is it.
Thank you. Thank you, Dr. Ritu, for bringing different aspects about this case. I think the most important thing is more than the corneal opacity, you have very appropriately used hooks to give good clarity. And in a very shallow AC, I personally would also like to use hooks as against a more bulky Malayugan ring, but I think it is a very individual choice at that point of time. But you know, it is very important to crack the posterior plate. So we need to have adequate dip exposure. We should bury it adequately right in the middle third, and then do a crack or do a stop and chop also. If you're doing, we should have really thinned out the posterior plate. And of course, sometimes you can even make a small crater, and that allows you to get a better purchase in some of the denser cataracts. But besides that, I think I would have done one more thing. If I was actually sort of sure about the laxicity, I would have placed a CTR. Immediately, if there was a doubt, I would have continued to do remove the nucleus, ensuring that I keep injecting viscoelastic and distend the bag. But even afterwards, if there is a feeling that the posterior capsule is lax, I would think it doesn't take much time to slip in a CTR. But that was a absolutely honest way of telling all the challenges which can come to any of us at any point of time. And of course, I would have maybe not placed this, if I was not going to place a CTR, and I think it's just that I'm imagining a posterior capsule being lax, I would have at least placed a 3-piece IOL.
I agree. I could have placed a CTR, I feel, in the end, before putting the lens. I think also a CTR would have been a good choice.
Dr. Arun Jain, are you there?
Yeah, I'm there.
Yes, you have your thoughts? Very brief.
I'll be very brief, not as extensive. You have covered almost everything, but very nicely done, Sarji, Dr. Ritu. I just wanted to ask that there was anterior synechial adherent glaucoma, it was?
Yeah,
Yes.
the patient had a perforating corneal ulcer earlier.
So in that case, that gives a false feeling of having a shallow anterior chamber. So in all cases, I have done a lot of cases like this. And in these cases, before I go on to start phaco, I will just cut the synechiae with long Vanna scissor, if it is at the opposite end, so that you get a deep anterior chamber.
Yes.
And another comment in your case is maybe you get a donut swelling of the conjunctiva in your case. So there is a lot of pooling of fluid within the over the cornea that makes surgery very difficult.
Yes.
Very difficult. So either you should drain it by making puncture, or you should amend from wherever the leak was happening. Otherwise, a very nice surgery. And in such type of cases, I usually do a direct chop without doing anything, so that you don't have to go around the nucleus. Just bury the needle in the center and do a direct chop. And by hand over hand sort of technique, separate the pieces till the posterior plate, so that you get a clean pieces. Otherwise, nicely done surgery.
Yes. Dr. Purendra Basin or Dr. Sanjay, one of you can add something before we go on to our next case.
Yeah, just that normally we are used to using the rings, like you said, but this is one of those situations where rings are not indicated at all, because you're only working on a segment. So the hooks is the way to really open up and work around it. Otherwise, I think the case was very well managed.
Yes.